From an annoying runny nose to life-threatening reactions, allergies. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is away. I'm Dr. Jill Kruse with Avera Medical Group Brookings. Allergies can come from a variety of sources: cats and dogs, ragweeds, insect stings, peanuts, and more. The range of reactions vary widely as well. We will explore why they happen and what we can do about them. First, let's take a look at this week's Prairie Doc quiz question. Epinephrine, as in the Epipen, works by A, increasing blood pressure, B, decreasing wheezing and improving breathing, C, increasing heart rate, D, decreasing hives and swelling, E, all of the above. We will have the answer at the end of the show. Joining us tonight are Dr. Tom Luzier with the Aberdeen Asthma and Allergy and Dr. Mark Bubak with Dakota Allergy and Asthma. Tom, let's start with you. What's the most common allergy that you see in your practice?
It's kind of a toss-up. Ragweed is the one that we see most often positive. Probably peanut comes in there at times, and Dr. Bubak's going to talk a little bit about the new peanut kind of thing. Dust mite is very high in this area, even though we don't have a lot of humidity in the wintertime. We do have kind of on the second strata dogs and cats. So ragweed, peanut, dust mite, dog and cat, and probably grass should be thrown in there since we live on a grass prairie.
All right, so not much shellfish in this landlocked area?
No, we're not.
South
Japan, yes. South Dakota, no.
All right. Well, Mark, what's the biggest change that you've seen in treatment?
I think that we really have some wonderful asthma therapies. The inhaled steroids, inhaled corticosteroids we call them, make such a difference. When we look at how many people were in the hospitals 25 years ago, allergists had wards full of asthmatics in the beds getting all kinds of therapies. And now it's rare that we ever have anybody in the hospital if they're actually taking their treatments.
Wonderful.
It's exciting.
That's a big change. And have allergy shots changed as well? I remember my older brother going in for a long time.
I think the thing that's changed most with allergy shots has been how successful they are. Because we've had other therapies, oral desensitization and things like that, but the allergy shots still come out way ahead. I mean, we try everything technically that we can do to make them better, and I do think that they've helped reduce the kinds of symptoms that come from that, sinus infections, asthma, that kind of thing.
The big change that I've seen is that we know the characterization of what's in the shots so much better that we can actually target more accurately. That's the problem with, say, sublingual therapy. We don't know doses that work except for 2 allergens. So, whereas with the shots, we know doses for most things, and it really pays off to get people better and not have so many reactions. It's wonderful. And that's new.
Excellent. Well, one of the first things we need to know is to just what exactly are you allergic? It is a simple but effective test.
Allergy testing that we're going to do today is prick skin tests. That's the traditional best way of doing the allergy tests. It tells us in about 15 minutes what the person has allergy antibody to. And we use it for people with itchy, sneezy, runny nose or asthma, sometimes hives. Jill will put these on. We've got a combination of some tree, grass, weed, mold, dust mite types of things here to see how things show up. A positive result looks like a mosquito bite, and we have positive and negative controls. And we'll read that off at 15 minutes. At times, a person gets a little needle under the skin. It's called intradermal, and that's a kind of a double check, especially with weaker allergens, to search out for allergies.
A lot of congestion, runny nose, coughing. I have the cough right now, so really disruptive.
That's more in the spring
eyes
for
turn
you?
red. Yeah, always in the spring, right away when everything's blooming. I react very fast.
After this gets done, a person needs to plan out a special treatment program for each patient. It's what kind of things do you avoid, and we'll give you avoidance tips. What kind of medications, and some of them need to be started before the season gets going. And then for quite a few folks, we end up putting them on immunotherapy or allergy shots or allergy drop type of things to make you actually less allergic over the years.
15, 25.
I've suffered from allergies ever since I've been a child, so over the years, of course, the treatments have been different types of meds, and they've worked to some various degrees. About 25, 30 years ago, I started with allergy shots, and I've been in various programs in the past, and the one I'm currently on is one of the better ones I have been on. And it's been going on for roughly about 15 years, I believe. And through that period of time, it's been a benefit. Noticed a lot of change in my lifestyle. I mean, I've been able to enjoy life a lot more, not having that stuffed up nose or face, and being able to go out and enjoy golfing and mowing yards and simple things like that that other people take for granted. Over all the years I've had allergy shots, I've only had problems with a shot once myself, and it was just a reaction, and it was a delayed reaction. It happened about 2.5 hours after the shot was given, which is abnormal. Most of the reactions, if you notice the placards in the building, they're within 30 minutes of the injection. I could start feeling your throat feel full and start getting hoarse and raspy, and you just sort of felt funny. So it was a typical reaction that you'd expect from an allergy shot. The other treatments I've been on, they'd make you tired or feel sluggish or slow, and you just didn't feel like yourself. And the thing I've realized with the allergy shots is you don't have a lot of side effects, or I don't have a lot of side effects from them at all, and that's made it a very good treatment for me, along with the family, along with the girls. You know, they've experienced the same thing that I have with their shots.
So the testing looked relatively painless and simple.
And quick, in about 20 minutes, you've got your answers. That's great.
So how many different things can you test for when you're doing allergy testing?
Well, we both have a standard set of testing, and this has been narrowed down by the FDA, who took a lot of antigens that we had capability of using because we never desensitized to them, so those disappeared. Technically, if it's a protein antigen, we could make something to test with, but I think my panel is probably 90 currently.
So a lot if you're going to go on allergy shots, you have all year-round stuff. We test for about 54 things that are pollens and the different molds and things like that. And there are lots of foods that we can test for. And so the big thing is picking what to test. You know, we have certain things that are available, but if you don't have exposure, you shouldn't be tested for it. And if you have symptoms in a certain season, you want to make sure that you test for those things.
So patients kind of come in and say, this is when I've had problems, and you can kind of help customize what you're looking for?
We have a lot of options because I have a lot of snowbirds that go to different parts of the country. Now they're going to get a different set of testing than somebody who's just going to be at home in Aberdeen, where I do most of my testing. But if they live over in Roberts County, they have a lot more oak pollen. We have like 2 oak trees in Aberdeen, which are well recognized. They have little fences around them. No, I'm kidding.
With foods, it's really important to only pick the ones that are potential for problems, because there's a high false positive rate with food testing, and we can get people into really bad diets because they avoid things that they don't need to.
And do people ever need to be retested as they get older? Do their allergies change?
Certainly.
Yeah, if we desensitize them, they really change, yes.
But yeah, there's the atopic march that we talk about, which means that, say like you're a little guy and you have eczema as a 1-year-old and you kind of get better with that, but you grow into your hay fever as a 10-year-old and a little bit of asthma. And by the time you're 40, you don't have much, and you're 70 and everything comes back. And what allergens are important at each of those stages can be completely different.
We've had a lot of change in what we test to and how we do that, because you mentioned that eczema in children, and now those eczema kids have a little higher rate of food sensitivity, and so peanut has really come forward.
Now, is the skin testing the most accurate way? I know there's some blood tests, but how good are they for testing for allergies? And
well, the blood test, the person that kind of brought the blood tests forward, because he was my mentor and wanted to do some remote allergy. In other words, just send me your blood and you get, and so we did lots and lots of those tests, and there are a lot of issues with the testing, false positives and false negatives. And as docs, we hate false positives and false negatives because it makes it very difficult to read. So I think that the blood test helps me when I have no other option. But that's very rare. I think the skin test, which is a biologic test, it tells you where the rubber meets the road. Is a much better test, much more accurate. Still requires some ability to read it, because we have people who have a thing called dermographism. Their skin is hives just when you mark on it. And so that requires some skill in interpreting those people.
And the skin test is about 1/3 the price of a blood test, and when you start doing 50 of them, that starts adding up for people. We try to do the skin testing. It's just better, true positive, true negative.
Well, you get the result right now too. That makes a big difference.
so fast, effective, and cheap. Why wouldn't you start with the skin testing?
Mainly if you just don't have access to it. But I like telling family docs and pediatricians, if you're just going to find out is Junior allergic to the dog, you might as well just get the one dog test. If that's all you're looking for, then you're done, and you find out, answer your question, move along. But if you're trying to figure out the whole sequence of things, it's probably better to get a consult.
All right, excellent. So any other things that people should be asking for referrals or talking with their family doctors about when is it appropriate to move on to see you in the clinic?
Well, we see lots of, most of our referral sources are, of course, from family practice physicians who recognize when antihistamines fail to work for upper airway congestion, when topical nasal steroid, which are now over the counter, fail. So we usually see the failure of antihistamine, failure of topical nasal steroid, or I can't take it. My nose bleeds, I have an issue with it. So those mostly come out of family practice. We do get a fair number of patients that come from ENT for that very reason. They've already developed sinusitis or polyps or something of that order. So we get a stream from that group of physicians. Then there's a lot of self-referral, because this is a family thing. And we commented with the little thing that it is, the little show that we had before. If your mother is allergic, you're going to have a very good chance of being allergic.
And I think that a lot of folks who have asthma, their cough and their wheeze, and that if the normal, simple preventatives aren't working, or you're really tired of taking the meds, or there's some avoidance, can we do immunotherapy to make you have a lot less asthma for the decades to come? That's where a lot of people come from. I think food allergy, trying to figure out, is it really that I'm allergic to this, and you need to sort things out. Most people are pretty good. Every time they eat some peanut, they break out in hives. It doesn't take many times, and you figure that out. But so we see a lot of.
Yeah, we get a fair number from pediatricians because of the whole food allergy, eczema or atopic dermatitis, the kids that have the itchy skin in their antecubital fossa here. I think we get a pretty good stream of very young children, which tells you that we can test as low as you want to go. Any age. And we can go as high as you want to go because your reactivity is still normal under those circumstances.
I really want to also point out that there's the wasp and yellow jacket anaphylaxis type of problems, and allergists can desensitize those folks, and hopefully with the next sting they get built up and you won't have the terrible anaphylaxis. It can be life-saving therapy, and it's nice to get those people and make such a difference. Especially like the beekeepers that they're making our honey, we like to keep them safe.
Definitely. So I think we have an animation that shows how the nasal steroids work, since that sounds like a place where a lot of people start. Maybe Dr. Bubak, you could kind of talk us through how to do it correctly so you get the most bang for your buck.
Okay. Is there some place we click then to get this started?
Oh, yep, it's going on the...
Okay,
There we go.
We got it running there. When we do a nose spray, it kind of goes up the nostril. And how does this turn on? Oh, golly. You'd think that we'd remember that. We try to have things go well. Anyway, when we spray up the nose, it's supposed to coat the turbinates here so that they don't swell and drip, itchy and sneezy so much. So the correct technique is the nostril, you take the nozzle, just barely put it inside your nose, aim slightly outward, and squirt a couple of times and flip to the other side. It takes a few days though for it to start working.
Right. I tell people to look at their toes when they spray their nose. So that
Good thing to remember. And I know a lot of people think their nose mainly goes up. It goes back quite a ways.
Straight back. It's the roof of your mouth is the floor of the nose.
Good thing to remember. So,
do you want to talk a little bit about peanut allergy?
Sure.
Since it's controversial.
I think what we're finding nowadays is how do you prevent peanut allergy? And there's certain risk groups that are very high rates, and so if you have eczema, atopic dermatitis, you and your family are going to have an increased incidence of peanut allergy. If you have egg allergy, you're more likely to develop a peanut allergy. And so there was a LEAP study where you take 4-month-olds that come from families with allergies, or especially the kids that have atopic dermatitis and or egg allergy, and should you feed them peanut at age 4 to 6 months and continue it on, and does it decrease the rate of allergy to peanut? Because for years we said don't feed any of our kids peanuts till they're like 2 years of age, and so the United States has the highest rate of peanut allergy. And so if you do it early, we're able to cut the risk down a lot. And so it's like 2% of these kids, if they're fed early, would develop peanut allergy versus 14% if you avoid it. That's in a group of kids that have negative allergy testing at the beginning of it. If you have a little teeny positive, it's more like 10% of kids develop it if you feed them versus 35% that if you don't feed them. So it makes a big reduction by feeding those kids.
okay. And can you explain the atopic dermatitis a little bit more? What should parents and grandparents be watching for? What does that present as?
It's itchy skin, it's rash, it's often the kid's face and head, especially down their lower outer legs. Little kids, it's even on their trunk. And it's kind of a rash that itches, and the more they scratch, the worse it gets.
We used to call it an itch that rashes.
Okay.
Because the itch comes first. And atopic dermatitis is very interesting because when they studied the skin, you're missing a protein called filigrin at the same rate. So what happens is the filigrin keeps you from losing water, which sounds weird, but it is. And that when the water leaves your skin, your regular layer keeps it from doing that. When you don't have the filigrin, it comes out and makes it itch. That's the bottom line. Don't have filigrin, you're itchy. So then the itch is more in these folds because they happen to lose a little more water, and so you have this dermatitis. And then there's this odd association of this filaggrin and atopic dermatitis with allergy. So some think that the allergy occurs because the antigens get into the skin because it's not protected anymore from the keratin layer, and this filaggrin is gone, and so the antigen gets into the skin and does the sensitizing. And so that's one of the theories.
The dust in our kitchens,
Right,
as the
dust
kids
in
are
our
just
kitchens.
playing and stuff, it lands on their skin, and that's how they become sensitized early on. Whereas if you're eating the food, we're set up because we have to eat food, so whatever we put it through our mouth, we want to be able to tolerate so we can eat it. And so tolerance develops orally, whereas on the skin you can develop the allergy a lot easier.
It's a pretty cool deal that they have, that this has been discovered, because when I tell patients, these are mostly young kids, is that the creams that we use, I don't use many lotions because lotions are too thin. I like to use a cream that actually acts like a barrier or a cover, and if you rub it in real well, it actually kind of substitutes for the filaggrin that you're missing, and there's a number of really good products for this. And then if you're really fancy, you can put something over the top of it like an ointment, like Aquaphor, or sometimes Vaseline. We use Aquaphor mostly. And that way you've created a barrier so the stuff that's coming in doesn't get on top of it. And then the other barriers, they're closed. Very important, and so that's kind of a part of it. I happen to be a soaker. I like them to soak in the tub, and then when they come out, pat them dry and then put these products on. I think it does a good job of keeping the skin intact so these other allergy things don't happen.
Well, aside from peanuts, is there anything else that people can do to try to prevent allergies from developing?
Well, we think early feeding is really the one for the food sensitivity.
Picking your parents would be really the handiest.
Thank you very much.
Yeah.
Exactly. Picking your parents. We say that a lot in our office. There is another situation when you look for inhalant allergy. German children who grow up with their farm animals inside of the house, basically, they're just a barn away. Those kids have fewer allergy than do kids who are not exposed, primarily cattle is what we've seen. There has been an association with dog exposure and less allergy if you were exposed, your mom was exposed and then you were exposed as an infant, having less allergy under those circumstances. Whether that'll, and bear out being a great thing, what you heard from Mark was we went from 14% to 2%. So there's still 2% that's a problem, but it's sure better.
Exposures to different, the agricultural styles has really been borne out with Amish versus Hutterite colonies, and that the Hutterites have a markedly higher rate of allergy problems. So there's somewhat of the hygiene hypothesis that you were talking about involved with that, we think.
Yeah, they even try to isolate Bacillus subtilis as the bacteria that seems to excite our immune system that suppresses allergy. So that's very cool.
All right. So take your kids to the farm and let them get dirty.
Exactly.
That's right.
All right.
Exactly.
With genetics I raised that before, but what even skipping generations and things, if you do allergy shots as a person, and then your kids will have fewer chances of having allergies. That's a new study that came out this past year. And how that goes, it's not while you're pregnant, it's beforehand. Something changes and you pass on less allergenic genetics.
You rewrite your DNA.
Wow. That's a story worth reading then. All right. Any correlation with breastfeeding that helping reduce allergies at all?
Probably the breastfeeding for 4 months is what's recommended from an allergy standpoint, if you can do that. It seems to reduce it somewhat.
One of the things that I tell from my pediatric standpoint is as long as you're breastfeeding, you do tend to reduce it because what's in the breast milk in regards to cellular does tend to suppress. But again, remember, we're using our GI tract. which is better adapted to tolerance and desensitization than what we talked about. Our skin and our nose, our respiratory tree, tends to sensitize a little bit more. So I think it really prevents allergy food. I don't know how much it prevents allergy inhalant, allergy skin.
How about smoking? Do you think that if people avoid smoking, it decreases allergy?
That's what they say. It's a pretty good correlation. Secondhand smoke and actual smokers. There's a whole plethora of things that happen to you if you're a smoker. I mean, your allergies are worse, your pulmonary disease is worse, your sinuses are worse, your immune system's worse. There's really not anything that doesn't get worse in regards to allergy and respiratory tree.
So if you didn't have enough reasons to stop smoking, now's another.
There's another
There's
reason.
another one.
Yeah,
All right.
absolutely.
So are farm kids less likely to get allergies than the city kids?
Yes.
Yep.
Yep.
You
We'll go with
clearly
yes.
see that. You clearly
Yeah.
see that.
Yeah, we see the kids that are people that have moved from the farm, and child 1 doesn't have much allergy, and now they're in the city, and child 2 does. Again, picking your family, they're usually allergic families also. Definitely runs in families.
All right. So it's good to get dirty on the outside around animals, but what about inside and indoor allergens like dust, dust mites? What do we do with them?
The dust mite is just and you know, we're not allergic to the mite himself. We're actually allergic to his waste product. So I said in another show, dust mite poop is our enemy. And the part of it's because it aerosolizes so easily and gets up into our upper airway. And prevention there really is not having much carpeting. Carpeting tends to enhance the growth of the dust mite by giving it somewhere to grow, whereas hardwood floors not as much. We do have some controversy about, we hear about allergen covers and that kind of thing. The data is so soft. We grade our data like A, B, C, D, F. And this is like C data at best.
About the encasements, right?
The encasements, yeah. They're
It's really hard to avoid enough dust mites to clearly make a difference unless you go higher than a mile or you really dry out your environment. And in avoiding the dust mites before you have allergy really doesn't seem to make a difference. Actually, the cleaner you are, probably the more allergies you're going to end up, inside avoidance is just as well as the outside stuff we were talking about.
And just like we said, you can do something with the skin to kind of protect yourself from having it get sensitized here, but you can't protect this very well. So again, I think the data is pretty soft on inhalant sensitization.
Okay. Well, the Epipen can be life-saving when used correctly in the event of a severe allergic reaction.
So we're going to do an actual demonstration. This is not a practice pen, this is a real pen. I'm not having an allergic reaction, but I'm not afraid of it because I know I've got good guys to protect me, but it's a safe thing to do even if you didn't need it, right?
Exactly. I mean, this is a wonderful demonstration.
So we should not be afraid to use it if we think we might need it. How would you might need it?
If your throat's swelling, you're itching, hard to breathe, feel like you're going to throw up, any of those things are signs of an anaphylactic reaction.
Particularly if you know that you've had a previous reaction, or you've been stung and you know that there's something, I call it the feeling of impending doom.
Yes.
And you should do something.
Something to do. So I'm having that impending doom. I was just bitten by a wasp, stung by a wasp, or I just ate a peanut and I'm in trouble, and I know that if I do this, it's not going to put me at risk, and if I don't do this, it's going to put me at great risk. So I want to do this. So this is the Epipen. There's another product. They're both the same, right?
Yep. Right. They'll do the same thing. They'll
Okay.
save your life.
Quickly, within a couple of minutes, help turn that allergic reaction around.
All right, and then you get to the emergency room.
Yes, you do.
All right, so this is a real pen. I'm going to take it off the top, and I'm going to
Take
bring
it out of the protective case,
All right.
get rid of that.
Throw that,
The
and
blue
then
pin comes out,
the cover comes off.
throw it away.
All right,
It's fully armed.
fully armed. Now we're ready.
You ready?
Put on your thigh.
I put it on my thigh through my clothes,
Yep.
Through your clothes.
and then I'm going to push it in.
And hold it for 10 seconds. There you go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Awesome.
Pull up.
I could feel it.
Way to go.
It hurt a little. Not bad.
Not much.
No, just a surprise because
And-
you've
yeah.
done,
And in a
done it.
minute or so here, you're going to feel that your heart starts beating fast.
Okay.
And you'll feel a little jittery, like you just got scared at the movie theater.
Or had way too much coffee.
And
Or
that-
I was going to
that
give a
swollen-
trumpet solo.
The
give
swollen
it-
throat, the itchiness is going to start receding, and you'll be feeling a lot better, and you can make your way to medical care now.
Very good. That's great. Thank you for providing us a pen and for being here.
Well, thank you
Two
for,
wonderful
for,
allergists.
you for actually demonstrating it. That was
That was
awesome.
nice.
So Dr. Holm definitely was there to show us exactly what it's like. But could anything bad happen if you use an EpiPen, or if you use it and you didn't really need it?
Yeah, I think the hazards of an EpiPen are greatly overblown. Basically, when you get scared at a movie, your own EpiPen goes off and you get a little bit faster heartbeat and things like that. The reality is, even if you have bad heart disease, if you're having anaphylaxis and can't breathe and you don't have blood pressure, you're going to have problems because of that. And so basically the risk is small and the benefits are great.
And you remember that when we used to be in the emergency room and somebody comes in with a cardiovascular event, i.e. my heart stops, we used to use epinephrine, and we even used epinephrine intracardiac. So the whole cardiac vasoconstriction thing is really not something that is in play, because just like Mark said, you don't use it, that loss of blood pressure is very, very dangerous. That's the thing that gets us into trouble and is difficult to reverse. And the EpiPen is the antidote. The sooner you use it, the better it works. The sooner you recognize it. And the hardest thing is for us to do is to get people to use it. I mean, I can't tell you how many times somebody has come in, they've had a systemic reaction, not anaphylaxis, dropped their blood pressure, that kind of thing, and have not used their EpiPen. And I always say, if you would have used your EpiPen, this episode would have been a lot milder. It's just the fear, I think, of this mechanism of this self-administering and self-injectable
Getting a
pen.
needle into you.
Exactly, but you know, diabetics do it all the time. I mean, we have a whole list of people that use needles all the time. MS patients, I mean, we have a lot of them.
The other good news now is that it doesn't cost so much.
Yeah,
It's-
that was a big
You know,
deal.
if it's $300 for one shot, some
think about
people
it.
were wondering about
Yeah.
it. But we have some new options. The EpiPen generic came out. There's the Adrenaclick, which is a different style epinephrine injector, and there's a generic of it, and the LVQ is coming back. So there's 5 different ones, and there's more intense competition. So the prices are coming down, special deals being made. So people can get their EpiPen, or epinephrine injectors, as we probably should call them now.
All right. But they do no good if they sit in your car, or if they sit in your purse and you don't use them.
Don't let it sit in your car, by the way, because epinephrine is very sensitive to heat. So leaving it in your purse in the car or leaving it in your truck is a very bad plan. It needs to be in a cooler. It does not survive heat very well at all.
Like the 120, 140 in a car.
Correct.
All right. Like, how many pens should people have? Should they have, like, students have one at school and one at home, or one at grandma and grandpa's? I mean, how many of these do you have stashed around?
Well, my patients usually have at least 2, because you have to remember that many people in South Dakota are at least 30 minutes from any type of healthcare facility, and if you're out west, it may be 45 minutes. So I have patients who have multiple pens, depending upon what they are anaphylactic to and that kind of thing. My bee sting people being the ones that I really encourage getting desensitized so that they don't have to depend on the EpiPen, because the EpiPen is notoriously not on the patient when they get exposed.
So, 2 things here. One, what you're pointing out is that an epinephrine injection usually will help somebody for about 15 minutes. And then the drug's metabolized and the effect is wearing off. So if you have a second one around, you can administer the second one, help them out, breathe, and get their blood pressure up again while they're on their way to the ER. The other question is, how many do you need to have around? And it's really kind of a family decision. If you always forget it on you, it might be nice to have it at grandma's, so at least it's available.
And should it be stored in the fridge, just at room temperature? I mean, avoiding hot areas, but other than that, any other special?
No, it's room temperature. It's designed to be at room temperature, so that would be my advice, would be to have it available. And just like Mark said, trying to transport it to grandma's, the two grandmas, and all of this kind of thing is woefully inefficient. So having it at the places that the child is or the adult is the most important thing.
All right. And you said after you use it, you should still go into the emergency room because it's going to wear off and...
Should be evaluated, absolutely. I mean, there's always some, yes, it works beautifully and that kind of thing, but there still are issues with venom exposures and food exposures.
How long is your anaphylaxis going to last? That's the big question.
Well, there's two phases to it.
And if it's a 2-hour thing, it might be nice to be where they have more of the medicine to help you out. And that's the whole idea of getting to medical care.
Yeah, allergic reactions have two phases also. There's the immediate phase, and then there's a second phase too that can happen anywhere from 2 to 4 hours, and it can be equally severe. So it's good to have somebody observing you after you've used that EpiPen.
So do you use it if you just break out in a rash, or do you use it when the lips are tingling, you feel the throat? I mean, at what point in the reaction, how do you know if it's going to be bad enough to need the pen versus just taking some Benadryl and waiting?
Well, again, we're the allergists, so we're very aggressive with epinephrine. I mean, I use epinephrine in my office on patients that have systemic reactions to their shots very early because I know how well it works and that it really is the appropriate antidote. So the answer to the question is, I want you...
Case.
Yes, exactly.
If you're at home and a person, the little junior has a little something to eat and he gets 6 hives on his face and is talking, playing, that's just going to go away by itself. The Benadryl is going to take 30 minutes before it even starts doing anything, and so all it helps is with itch. So I tell people, don't even worry about that. I worry that the voice starts changing, they start throwing up,
Coughing.
they're turning, coughing, wheezing, if they're looking lethargic, all those are signs that you give that epi.
The little guys really get kind of floppy when this occurs, and it's real obvious that something systemic is happening. It's not subtle at all. At least it hasn't been. I haven't seen any very subtle ones at all. So I'm very aggressive with it. I like them to use their EpiPen and then decide what they're going to do.
It doesn't really hurt you much. Your heart races a little bit, and now the price is better. So.
Okay. So use it if there's any concern or doubt. Better to be safe than sorry.
Yeah,
exactly.
Yeah.
All right. So, and then with food allergies, do they change over time? I mean, I know my brother had an allergy to corn when I was little, and I learned that if he said that, he didn't have to eat it. So whenever I went to my friend's house and they served something I didn't like, I suddenly developed an allergy to it, so I could politely decline. But
you were really smart as a child. That's very clever. Yes, food allergies do change. Mark alluded to it, is that we see a little more allergic disease, or a lot more allergic disease, in that 1-year-old to 5-year-old group, and then we see a little bit less, and we see people that we've tested to cow's milk antigen, and it's positive, and they have symptoms associated with it, and then they're 5 years old and those symptoms seem to abate. So there's certain antigens. I think egg is probably the one that shows the most positivity and gets better as much as any antigens.
Milk and egg, almost everybody outgrows that before they graduate from high school. That's kind of neat, and very few people, it's probably 18% that outgrow nut allergy ever in their lifetime. And that's so. It's antigen or allergy, what the food stuff is makes a big difference.
Right. The fish antigen is kind of interesting, just for conversation, in that the fish antigen You don't grow out of very easy, and it's heat stable, so when fish is cooking and it's aerosolizing, you can have an allergic reaction from the fish cooking. So we have people, same with shellfish, that go to that Benihana thing and they're cooking it in front of them, and the guy has an asthma attack and can have a systemic reaction just like he ate it, and he just inhaled it. So it's a very unique
I think
protein.
people worry about that with peanut, and it's very rare that inhaled stuff is a problem, even on a plane nowadays. Yeah, it's been shown pretty nicely. You need to wipe your seat off for your child's seat, and that way you don't touch it and bring it to your mouth.
Right, it's
Been a
not an
concern.
aerosolized one, it's more of a handheld moving kind of antigen. Right.
I think it's good to say too that if you have, say, the peanut butter stuff on your skin, you're going to get some hives locally, but you actually have to eat the peanut to have anaphylaxis. So once we understand that, it makes the anxiety level so much lower for not only the patient but the parents. Going to school, you know, if a person has a little on their hand, wash it off. So it's important to realize that.
We do have practitioners that have done a lot of work in the peanut and have orally desensitized kids. And Mark and I have embraced this by looking at it, but it is a very difficult thing to do. You have to have very little doses. You put them in little medicine cups. And the biggest disadvantage, I think, is that you cannot miss your day with your peanut butter once you've been desensitized, because your chance for anaphylaxis returns even with a very small gap. So it's not very practical.
Probably 25% of the patients on their 3-year treatment anaphylax randomly with their doses. And then once you quit every day, most people relapse within just 4 months. It's about 2/3 of patients relapse and have their anaphylaxis again. So it's interesting, and it's neat though that some people can be desensitized. And then there's the new patch that's been worked on, and it just doesn't make you less allergic enough to be practical yet.
Okay.
But a lot of research going into food allergy.
Now with like environmental allergies, is it best to try to limit your exposure? Like if you're out cutting the grass or you're dusting, should you wear a mask? Is that going to help limit your exposure and limit your reaction?
A barrier is very helpful. So we have a lot of people that, lawn mowing is a very popular sport in South Dakota. And the larger the lawn you mow, the better. And so yes, masking helps probably as much as any medication you take. As a matter of fact, medication, because you're getting such a big exposure over a long period of time, usually is not very successful in causing symptoms to be significantly reduced, particularly the symptoms that night after you've done this lawn mowing. So yes, I'm very big on a mask. I like the N95 mask because it has a button in the front that when you exhale, it doesn't stay in the mask, so that's a very good thing to do.
Most people don't really like to wear those, and they feel stupid,
Especially if they have
stupid wearing it, and so I find it's pretty non-practical to do that.
So, but don't let your vanity get
Correct.
in the way of
We
preventing you from
shouldn't,
suffering.
but we do.
I think actually I've been surprised. My farmers actually have done a pretty good job because they know they get real sick if they're in a grain bin or something like that in wearing some kind of protection. They even have a helmet, a positive pressure helmet that's very successful when you have to be in it for a long period of time.
And you said the N95 mask, is that different than the ones they can just pick up at Walmart, or what
Yes.
should they be looking for?
Right. N95 is usually at your local, like a Menards or something, has a little more sophisticated masks, and they work a lot better. The little paper masks are the ones that, as Mark said, very few people wear them because they just melt on your face on a hot day. And you can get used to wearing a mask, but like Mark again said, most people are not big fans of wearing masks while they're mowing lawn for 5 hours.
Well, I can't blame them. So, and we were talking a little bit about you can't pick your parents, but is there anything the parents can do, moms can do during pregnancy to try to limit their children from getting allergies? You know, taking fish oil, is there any merit to that, or is that an old wives' tale?
just being desensitized as a mom who's allergic will reduce the allergy in your child in your subsequent pregnancies.
All right,
That's
so
what you
about it.
do.
take
That's
care of
about it.
yourself first.
Right.
And don't worry about what foods you're having, eat a healthy diet. And
We don't typically desensitize while you're actively pregnant because the small risk of a systemic reaction is kind of, because you've got two people involved and that kind of thing, we don't do that as a rule. So we really like to do it outside of the pregnant state. But we don't, if you're already being desensitized and you're on shots, we just stabilize the dose and we keep it up. So it's of value if you're planning on being pregnant.
So how long does the desensitization process take? Is it months, years? Is it kind of an ongoing, indefinite?
allergy shots are typically thought of as 5 years. We know that you have to do 3 years. If you do anything shorter, once you stop, you relapse, and all your hay fever type symptoms would come right back. And so it starts out busy. It's a couple times a week. By the end of about a year, it's pretty close to a month, once a month that you're doing it. So it's not so bad at that point.
Okay. And that's something that's done at a doctor's office? It's not something you do at home by yourself?
You do it at a doctor's office. It's much safer, and moving most all the shots to the doctor's office has really made it a much, much safer treatment for people. People don't die from allergy shots now. So that's
The other thing is I think consistency improved a lot over the home shots. They showed that people would forget and then they do them in a haphazard way, and that doesn't work whether you use it for 3 years or 5 years. The thing that he was alluding to is actually very new information, because they took people that just did shots for 1 year, one did just for 2 years, just for 3 years, and then would stop them and see if their allergy comes back. And it was a very good study. It's one that should have been done before, and this is very good information. What they've developed in that 3rd year is called tolerance, and that's the thing that we're aimed for. You can desensitize a person pretty quickly, but for them to develop permanent tolerance or semi-permanent tolerance is the thing that we're aiming for.
really great when you don't have to take so many meds and you don't have to take the shots anymore.
All right. So I think this is wrapping up our time here. So we'll get the answer to tonight's Prairie Doc question. So you watching out there, have you figured out how epinephrine works in the Epipen? Does it work by A, increasing blood pressure, B, decreasing wheezing and improving breathing, C, increasing heart rate, D, decreasing hives and swelling, or E, all of the above? Well, I think these gentlemen showed us that E, all of the above, is our answer here. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
He had no complaints, like many men who come to my office for an appointment scheduled by their wives. But as I was asking routine questions, he told me that food sometimes catches on the way down. Since this symptom can be an early sign of cancer, I scheduled an EGD to look at his esophagus with a scope. We were both pleased it wasn't cancer, but I was surprised to find another case of what used to be a very rare disease called Eosinophils Esophagitis. It was the second time I ran into this in the last few years, and I was aware of a few children in town who also had the diagnosis. It was one of those conditions you hear about as a med student but never see, except now we're finding much more of it. Eosinophilic esophagitis, or EE, is characterized by an inflammation of the esophagus and the finding under microscope of many of a special type of white cell called eosinophil. We've learned this diagnosis can occur in young children to older adults with symptoms of reflux, trouble swallowing, even food catching or getting stuck. It's interesting how EE brought specialty groups together. First, the pathologists started seeing more eosinophils on pieces of esophagus biopsied, both by pediatric and adult gastroenterologists and patients referred by pediatricians, internists, and family physicians. Since eosinophils are an indicator of an allergic process, the patients were then sent to allergists who put it together. We've discovered it's generally related to food allergy. Cow's milk, the most common offender, and is treated by avoidance of the allergenic food, by anti-reflux medicines, and by swallowing a steroid spray that is usually used for asthma. And we're not sure why this formerly rare disease is happening more often now, but we have our suspicions. Of course, C-sections can save lives. Baby formula is sometimes necessary, and less dirt means less infections. But we think EE might be secondary to our overly clean environment, sterile baby bottles, and our too persnickety way with the food to which our babies are exposed. Imagine that. There might be an advantage for babies who come down that non-sterile birth canal, who suckle up against mama's breasts awash with normal flora, and who are exposed, not protected, from the dirty world in which we live.
A big thanks to our guests, Tom and Mark. You're both great friends of the show and have always bring a lot of interesting discussion to us tonight. And as a reminder to you at home, vaccines are not just for kids. Check with your medical care provider to see if there are any vaccinations you should be getting. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Can't get enough of the Prairie Doc? Then visit our webpage and other online programming. You'll find extended interviews with guests and more information on important medical subjects. Visit prairiedoc.org or follow us on Facebook. The best way to stay healthy out there.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota State Medical Association,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen Asthma and Allergy,
Black Hills Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Regional Health,
Swiftel Communications.